Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the attendance, or rather the program evaluations, and turn those in. And if you could give us any ideas in regards to future topics or future speakers, we would appreciate those. And also please remember to turn in the audience response cards. Today I have the pleasure of introducing Dr. Douglas Lake. Dr. Lake attended medical school at the University of Kansas and then did a residency in radiology at the University of South Carolina before going to Stanford and doing a fellowship in MRI. He is the latest addition to the Department of Radiology here at McFarland and MGMC, and he kindly has accepted our invitation to update us on diagnostic radiologic imaging. And please join me in welcoming Dr. Lake.
Okay, thank you very much. All right, so we're back in business. So there's Caroline. This is Caroline. This was her yesterday.
Thank you. Hi.
Narrated by my wife, Malia.
Hi. Yeah, hello. Good morning. Hi. Yeah.
She bounces when she's happy.
Good. You're definitely a morning person, aren't you? Hello. Hello.
Oh, okay.
And the
No
other
problem.
hand. There you go. Switch, switch, switch. Hello. Hello. Hi. Yes, yes, yes. Hello out in the hall. Hi. Hi.
So that's our Caroline Bearline. Like many of you, I own mutual funds, and mutual funds own stocks, and so I do indirectly own two of the entities that I'm going to talk about today in GE and Hologic, but they don't have any bearing on what I talk about today. We talked about the three things that we're going to talk about in hemangioma or something else. So hemangiomas are a benign tumor of the liver composed of multiple vascular channels lined by endothelial cells supported by a thin fibrous stroma. On ultrasound, you're going to classically see a homogeneous hyperechoic lesion, and you sometimes see a little bit of posterior acoustic enhancement. So the arrow points to a hemangioma in the liver. Behind it, you can see an echogenic line. That's the diaphragm. But behind it, you can see an open-faced arrow where there's a little bit greater echogenicity passing through. That's a classic appearance for a hemangioma, and Mike Federley loaned that picture to me. From the McFarland Clinic, we've got another hyperechoic lesion. This is the best looking hemangioma that I could find from the cases that I looked at in our system. Can we get the lights down a little bit? These front lights, it might project a little bit better. But that's another good appearance for hemangioma, fairly homogeneously hyperechoic, a little bit of decreased echogenicity in the dorsal aspect of the lesion with posterior acoustic enhancement, the greater whiteness of the diaphragm behind the lesion. At CT, we see centripetal peripheral nodular enhancement of hemangiomas. You see this nodular enhancement around it. That will coalesce over time when you take multiple phases of CT imaging. This will fill in over time. Sometimes it fills in immediately at the first set of images. Later times it takes longer to fill in. Hemangiomas can be large. This is a giant hemangioma. They also, when they get large, can have a central scar. And this is a good example of a giant hemangioma. This is an even larger hemangioma. It occupies the majority of the left lobe of the liver. A large central scar is that black sort of triangular area with the open-faced arrow. And then the curved arrow points out calcification within the scar. It's just a massive hemangioma. MRI, we see a typical pattern for hemangiomas. They're typically very T2 hyperintense, almost the same signal intensity or whiteness as the cerebrospinal fluid of the spine that you can see there. Again, when they get large enough, they can have a central scar, which can be misleading sometimes and make us think about focal nodular hyperplasia. Nonetheless, this lesion does show peripheral centripetal enhancement. So this is our first unknown case where we'll try the audience response system. We've got a mixed echogenicity lesion, fairly well circumscribed in the right lobe of the liver. We've got transverse and longitudinal images. You can see the border. It does look like the diaphragm is slightly whiter behind the lesion. Okay, MRI that was also done here at the clinic shows T2 hyperintensity, not quite as bright as the cerebral spinal fluid, but pretty close. And then on the post-gadolinium images, we've got progressive centripetal peripheral enhancement that's not completely coalesced on the final image, which is the right lower one, but it's pretty close. So we'll try switching over here. Excellent. And so our choices are hemangioma, hepatocellular carcinoma, METs from an unknown primary, focal nodular hyperplasia, or hepatic cyst. We can I'm curious to see what this, and I guess we can look at the results. We can close the polling or whatever. Okay, good. Most people said this is a hemangioma. Good. Good. This is what this is. It's a classic hemangioma. So, digital breast tomosynthesis. A little bit of background on breast cancer. In 2015, there were more than 230 estimated occurrences of breast cancer, and with more than 40,000 breast cancer deaths in just 2015 alone. Mammographic screening is a little bit controversial in some minds, but it isn't very controversial in my mind. I do believe that screening definitely detects disease earlier than it can be detected otherwise, and does improve survival by reducing breast cancer deaths. Digital mammography, though, is the inherent problem is just like a one-view chest or a two-view chest. You're imaging a three-dimensional structure in only one or two projections. When we can take circumferential images, or at least angled pictures of something, we have a better sense of its three-dimensional appearance overall. And that's one of the weaknesses of digital mammography, is that we're just taking two-dimensional pictures of a three-dimensional structure. So DBT is a better mammogram. It's been written, it's not my term. We take multiple low-dose projection images of the breast along an arc. The X-ray tube pivots in an arc of varying degrees. It depends on the manufacturer. Some manufacturers have 15 degrees of arc, some have greater at 50. The projection images that are obtained then go through a Fourier transform, which is a fancy mathematical equation where they, in 3 dimensions, say where things are. It can either go through filtered back projection, which is a way of doing this, or iterative reconstruction. In all manufacturers, these 2D images that we are able to view are typically 1 millimeter images, and we look at all of the images that are obtained. So 2D mammography, traditional digital mammography, or screen film mammography, you can imagine that there is an oval breast here. We've got X-rays are representing the arrows coming from above, going through the breast, and being detected on a detector plate below. The breast is compressed by a compression plate. We have a cyst in the 6 o'clock position and then a spiculated cancer in the 12 o'clock position. You can imagine that in this scenario, the two structures superimpose one another, and in this projection, you just won't see the cancer because the cyst is in the same projection and is more dense than the spiculated cancer. The picture on the lower right is illustrating the same concept, that we've got multiple masses present in this breast and a spiculated red cancer, and it's really hard to see the cancer because of all of the overlapping structures. This is another diagrammatic representation of what tomosynthesis is. So we've got either a red or a tan breast, I didn't pick the colors, here, and then we have an X-ray detector below it. We've got a compression plate above, and then the X-ray tube begins an arc that starts here, takes pictures, and then rotates continuously, at least for the hologic system, and takes 15 pictures of the breast in multiple projections. The same occurs in this set of images where we're trying to show that the compressed breasts with 15 images are taken. I have no experience whatsoever with this is a diagram of all of the different DBT systems by manufacturer. I have no personal experience or knowledge with the IMS system from Italy, nor with the Siemens system from Germany. We do have experience with the hologic system and the GE system. Hologic is what the McFarland Clinic and Mary Greeley Medical Center use. It takes a 15-degree arc of pictures, whereas the GE system that's used at Central Iowa Healthcare takes a 25-degree arc of pictures. Our system here takes 15 pictures versus 9 for the GE system. The scan time is 3.7 seconds. It's pretty quick. It doesn't, I doubt that folks perceive a significant difference in the time it takes to obtain the image versus a traditional digital mammogram. But you can see that the Siemens system takes considerably longer. That's a long time for somebody to hold completely still and to especially not breathe. We ask the patients to hold their breath while they take the picture. The tube continuously moves in the Hologic system versus GE's is a step and shoot. I don't think that I haven't seen a significant difference in that between the different systems. You can't perceive the detector moving, but it does move during the pictures. And then the images are reconstructed with filtered back projection for the Hologic system. The green box shows the McFarland Clinic. I tried to do blue to represent Mary Greeley's sort of color, and then the darker blue is the Central Iowa Healthcare color. An interesting side note, the GE system does use iterative reconstruction, which is another mathematical equation and greater computer power that's necessary to reconstruct the images from the image space to the two-dimensional space of viewing them. It takes more computer power to do iterative reconstruction, and if I were to predict, I'll bet that Hologic will, in the next 5 or 10 years, probably switch to an iterative reconstruction. The GE system does give us a little bit cleaner images, I would say, than the Hologic system slightly, but I don't perceive a significant difference between the two systems otherwise. Another diagrammatic representation of how DBT works. Again, we've got the same concept of a cyst and a cancer superimposed on one another if you're taking pictures from straight down. But if you take pictures from the angle on the right or the angle on the left, you're able to superimpose those structures away from one another with the angle, and therefore you have a better chance of seeing the patient's cancer. This is an actual set of cineing or moving set of 50 or 60 images through this patient's right breast. This was a diagnostic mammogram from McFarland Clinic. I intentionally chose this one because the degree of background fibroglandular density in this patient is relatively mild. There's also, as we scroll through the images or as it cines through, you'll see a triangular mass marker that comes into and goes out of focus. You're not exactly taking slices through the breast, but conceptually it's pretty close to that idea. So, I'll pause it here. The lower images are by default the images nearest to the detector. Oops. And the images that are higher are by default the ones closer to the head. If we come up high here, we can see a triangular mass marker in the breast here. As we come down a few slices, there is an area of spiculation in the breast here that as we scroll up and down on it, it goes out of focus because it comes into and is out of the plane of the slices that we're looking at. This allows us to localize where something is better. We know it's slightly medial to the nipple, which is here, and then we know that this is definitively in the upper breast based on just these pictures. With two-dimensional traditional digital mammography, we didn't have this capability. This is the patient's MLO projection, which is usually a 45-degree angled set of pictures. Same breast, same woman. As we scroll through the images, we've got a triangular mass marker here as well. And as we scroll through the images, if I pause it, we can scroll through the pictures. At about this level is where we can best perceive that there are these spicules of density that extend and radiate from the center of this cancer. It really does allow us to see the edges of these malignancies much, much better than before. The other reason I chose this case is because in this lady we were able to do a wire localization with DBT. And so we were intentionally localizing the cancer for the surgeon to surgically remove. And I think this also nicely illustrates how this system works. Because as we come up to the very top, we're out of focus of everything except for the wire. You can imagine a breast compressed in the CC projection, and a wire is coming from above and going down. At the very top of the breast, we're out of the breast, but we can still perceive the wire. As we scroll down through the pictures, we will scroll down to the level of this is the compression plate. And as you can see, it's come into focus because we're literally at the level of the compression plate. As we scroll further down or caudally through the breast, we continue seeing the patient's wire. We come further down, and then this biopsy clip comes into view. It becomes visible, frankly, because we're at the level of that biopsy clip. As we keep coming down even further, you can see that it's difficult to see, but the wire was going in a normal path, and then it sort of took an angle off to the side. That's the hook wire. This is a wire that comes down and has a hook that sticks off the end of it. You can actually see the hook wire. The lesion is not as well seen in these images because it's been biopsied in the meantime, and we removed probably a decent chunk of it. As we come further caudally through the breast, the lesion is no longer there. The wire is no longer there. We are literally in slices that are below the lesion. So does this really work? Do we really see things better? Do we really have a benefit that we can point to and say that this is beneficial? Yes, this is the largest prospective trial where they compared digital mammography with DBT, and they found a 27% increase in cancer detection rate and at the same time reduced recall rate, which is where we call someone back for things that sometimes are cancers and sometimes are not. Another trial showed a similar result. What do we see better? What is it that's so much better? I think that we see lesion borders better, which allows us to better characterize something as being a form of malignancy or something benign. Frankly, we really see architectural distortion the best at DBT. And this was another trial where they looked at BI-RADS 4 and 5 screen-detected lesions with both digital mammography and DBT. What we were able to see better was invasive lobular carcinoma. We were able to see more invasive lobulars with DBT than digital mammography, but it's not just invasive lobular. We're able to see a number of malignancies just better overall. Many of them were occult at digital mammography. So now I'm going to show you sort of a series of those sorts of images. In this case, this is a CC projection of the left breast. The upper part of the breast is lateral. The lower part of the breast is medial, just by convention. I challenge anyone to see the cancer here. There is retroareolar density here, and then there's a density in the far lateral breast, about 10 centimeters from the nipple. But on the DBT slices, the arrow points to an area of focal spiculation in the breast. That was the patient's cancer. This ended up being an intermediate grade invasive ductal carcinoma. This is one case where when you go back from the DBT image and then through I'm a big believer that the radiologist, we live in the world where there is a retrospectoscope. We can see back in time. And can you go back to the digital mammography picture and see this cancer? Even knowing where it is, I really struggle to see anything that looks abnormal there. It's really remarkable what DBT allows us to see sometimes. This is another case. We've got a digital mammography picture in the upper left, and then next to it is the tomographic image. In both, there is a asymmetric density. There's something that's whiter in the outer breast. This is that you can see. It's not till you get to the DBT picture that you say, there's a little bit of speculation around the edges of this. It looks sort of fluffy and white on the digital mammography picture, but on the DBT picture, the spicules are a little bit sharper and they can be better perceived. This is the MLO projection of the same area. On the digital mammography view, same thing. It's just a little bit whiter, yes, but it doesn't jump out at me quite yet. This is a subtle case, but there are more spicules that you can perceive at the arrow on the DBT picture. The patient went on to have an ultrasound, and there is a very typical appearing hypoechoic, ugly-looking cancer present. This patient went on to get a breast MRI, partially because of what the diagnosis was, and this is a T1 post-gadolinium subtracted image that shows this spiculated cancer. And MRI is certainly better at picking up things than mammography. It's the most sensitive modality we have, but it's very expensive and very time-consuming, so we can't use it as a screening tool, but we can use it to better see things. And in this case, this ended up being a 6-centimeter invasive lobular carcinoma. And this is the case for lobular. We sometimes just don't appreciate how big something is when it's lobular until we get to the MRI. So DBT really is this quasi three-dimensional. I like that description. It's not a true three-dimensional set of images, but it gives us a sense of three-dimensional viewing. And so one of the advantages is that from DBT, we can use ultrasound or MRI to better localize where something is when we only see it in one view. And this was another takeaway from preparing for this lecture, that was something that I'd always heard, that with digital mammography you should trust your CC projections a little bit more than your MLO projections, but that actually holds true with DBT, that in looking at 115 malignant cancers, 35% were either better or only seen at the CC projection, whereas 11% were better or only seen at MLO. There are some who have discussed or argued that maybe we should only do one projection and not, since we have this sort of quasi three-dimensional visualization, but I don't think that's true, and that's not what other places do. We still do two views, and the two views add value. This is an example of seeing a lesion in the CC projection better than we see it in the MLO projection. For whatever reason, it's probably overlapping structures, but in this case, we see this lesion in the CC projection medially at the arrow much better on the CC than we do on the MLO. And this represented an intermediate grade invasive ductal carcinoma. Another case where on the digital mammogram, this is a denser breast. This is a category C breast where there's heterogeneous densities, and we know that these densities make it harder for us to perceive the cancer, yes. But it's not till we get to the CC DBT images where the arrow is that we can see this area of spiculation. And it looks pretty hazy. When you get closer, you can see the spiculation around it. On the magnified view, there is a central density here, and then radiating out from it are these spicules of increased density. This ended up being an intermediate grade IDC with DCIS. So the largest trial, this was not prospective, this was retrospective, but it was a huge trial comparing digital mammography with DBT, looking at over 450,000 cases. Similarly, they showed a 28% improvement in breast cancer detection and a reduction in callback rate of 17%. They compared their utilization of digital mammography from 2010 to 2011 to using 3D breast tomosynthesis immediately after implementation, and found more cancers and had less callbacks. So this was a huge trial that was at multiple sites. This sort of inspired me to look at our own numbers. Let's see what was our performance when we look at McFarland Clinic, when we went from digital mammography to what did we get when we switched over. And back one more thing. This is there's a lot of centers, and I don't know exactly what all the centers were, but there's some big name places that were authors on this paper: MGH, Penn, Case Western. So there's some big private practice locations. This is a very busy slide. I'm not going to spend much time on it, but at the bottom we've got the McFarland experience, and I'll mag this up, But for the study average, for that trial, there were on average 10.7 radiologists at each center. We have 8 in reading at the time of our experience. We're a non-academic site. Our period 1 cases were similar. There were 21,000 on average for period 1 for the trial versus 16,000 for us. We're a little bit unique. A lot of these centers took out one digital mammography unit and put in one DBT unit. We took out all of our digital mammography units and replaced them with DBT because we felt that they were going to be beneficial, and we were effectively right. But we have more period 2 cases than in the trial. Interestingly, our cancer detection rate was 4.3 cancers per 1,000, which was exactly what the larger trial was. Our cancer detection rate went up to 5.0 versus 5.4 for the trial. So you might say, well, we didn't see as much of a benefit as they saw in the trials. We had a 16% improvement in our cancer detection rate versus 27 or 28%. What's interesting, though, is that we really reduced, and I don't think anybody intentionally did this when reading the hundreds and thousands of mammograms that we read every year. We didn't intentionally do this, but we did drive our callback rate way, way down, down 36%, way below the study average. This is a complex diagram, but I'm going to spend a little time on it because it's really valuable to help understand the concept of improving cancer detection and reducing callbacks. So if I've got a choice, if I can be any radiologist, I want to be right here. I want to detect 8 cancers per 1,000 women screened, and I want to have a callback rate of 4%. So this is where you want to be, all right? Where you don't want to be, you don't want to be here. You don't want to call back 18% of women and find no cancers. That's bad, okay? And a little humbling experience of mine, after I finished my first year of being in private practice, as a good radiologist, I marched down to Pam's office, who was the director of mammography at the hospital that I worked at, and said, Pam, I know you keep track of these numbers. Can I see what my performance is? Can I see how many cancers did I detect last year? How many people did I call back? Can I see those numbers? And she looked at me with kind of a funny look on her face. I think I was probably one of the few radiologists who'd come and asked her for that data. But she said, are you sure you want to see, Doug? And that should have been my first clue of no, I probably don't want to see, darn it. So I looked, and my callback rate was right around 14%. And my cancer detection rate, I had not found a screen-detected cancer yet. So I was here, and that's a terrible place to be. That's not where you want to be. That was a humbling experience and a learning experience for me, and since then I've grown and I've gotten much better at reading screening mammography. But that's where I was. This is not where we want to be. So where were we? With digital mammography, we were right here. We were right in the middle, which is a good place to be. Our cancer detection rate was 4.3 per 1,000, and our callback rate was about 11.7%. Now, where did we go? That's what's important. We went to here because our cancer detection rate was 5 per 1,000, and our callback rate was 7.4%. This is what I see as being an arc of ideal performance, at least in this trial. The centers that were doing the best job that they could, you trade off. If you intentionally try to, it's a sensitivity specificity issue. If you're trying to pick up more cancers, you are going to call back more women. If you try to drive down your callback rate, you're going to have a lower cancer detection rate. It's just an operating curve, essentially. So we're right here, which is a really good place to be, in my opinion. So one more thing about about breast imaging. It's not DBT. Some of the guys in my group are amazing, and one of them is Dave Susnowski. About a month ago, Dave said, "Doug, did you see this?" And it just was published in November, and it's a revised recommendation for the workup of palpable breast masses for women under the age of 30. Traditionally, we have done ultrasound and then not performed any mammograms unless we really felt that we needed to. The ACR recently changed its recommendation. If we have a woman with a palpable abnormality or an area of clinical concern, we start with ultrasound for all of them. If we find something that definitively represents what they are complaining of, we see a benign cyst, we see a fibroadenoma, or God forbid, we see a cancer. If we see a cancer, we'll do the mammogram. But if we see something benign, we don't do a mammogram traditionally. This algorithm changed recently and said that if you don't find something that correlates, you do need to do a mammogram in any woman under the age of 30. That caused me a little consternation, as it did some of my partners as well. And so we tweaked it a little bit. I saw an 11-month-old yesterday, actually, for a breast ultrasound, and I did not do a mammogram on the 11-month-old. I think that at some point you have to say, I don't think there's going to be benefit in doing a mammogram in these patients. So what we chose was that from 18 to 29 years of age, we will do the ultrasound first. We will review the case initially and see if there is something that corresponds. If nothing corresponds, then we will recommend a mammogram. If the patient is under the age of 18, we will do the ultrasound. We will review the case. We will talk to the patient and or the family. And then after that discussion, we will decide whether or not to do a mammogram. So, but it's important to know that for the pediatric age group, we may start doing an occasional mammogram here or there. So we're going to change gears again. We've got an abnormality in the right lobe of the liver. This was a MRI that came from an outside institution. We've got a T2 hyperintense lesion. We've got post-GAD images in the upper and then lower. We've got upper right is this one is pre-contrast. This is arterial phase. This is portal venous phase. This is the latest equilibrium or delayed phase set of images. And this is the coronal image of this lesion. We've got a normal stomach here. We've got a normal gallbladder here. We've got left ventricle here and right ventricle here. But this is the patient's lesion. And we can go back and our choices are, is this a hemangioma? Is this a hepatocellular carcinoma? Is this a MET from an unknown primary, FNH, or hepatic cyst? So and let's see what the results are. Okay, good, interesting. All right, so it's this, okay, good. This was interpreted at the outside institution, a large tertiary care medical center, as being a atypical hemangioma. I have said the words atypical hemangioma, and every time I do, I shudder a little bit, and I don't like saying that, because hemangiomas should have a typical appearance, or they should follow some of the rules. This doesn't follow any of the rules for hemangioma. There's no enhancement. There's a couple foci of enhancement that are next to the lesion. I think that's what caused the confusion, potentially, but I think they're just vessels next to the lesion. For those that said this was a hepatic cyst, that's a really good thought for this. The only things that I don't like about it for being a hepatic cyst is that cysts are usually round. They usually start out as being round. As they grow, they may change shape a little bit. They may get oval, and as they get really big, they'll start to scallop the liver because of pressure sort of thing that goes on as the cyst continues to enlarge. But this isn't big enough to start scalloping the liver. So this would have me concerned. And appropriately, the outside institution said, this lesion is, it's probably an atypical hemangioma, but we should compare with priors and all that sort of thing. Well, this is the patient's PET-CT 3 months after that MRI. And I read this one and had to make the uncomfortable phone call to one of our clinicians to say, this patient's MET to the liver has grown. And the actual clinical history for this patient was that, I don't remember he or she, I think she, had either rectal or distal sigmoid cancer that was biopsied and known, had a previous PET that showed that lesion to be very FDG avid. She underwent radiation and chemotherapy and was sent to a tertiary care center for evaluation for definitive treatment of her rectal carcinoma and oligometastatic resection of her hepatic lesion. Unfortunately, the opinion was that this lesion was a atypical hemangioma. The hepatobiliary surgeon that she saw said, well, this is just a hemangioma. We don't need to resect it. And unfortunately, she did not get her definitive therapy. She recurred, and this is her subsequent MRI later on. This lesion effectively was a cyst at the time of the MRI at the outside institution. It probably still had a few cells that were still active, but most of it had been effectively treated with chemotherapy. So patients who've received chemotherapy, they can have tricky appearances of their hepatic lesions is the real take-home point for me and for all of us. So speaking of tumors and what they do, tumor response assessment is an area that's important to me. I like being able to provide my clinicians the best information that we possibly can. It started out with WHO, the World Health Organization, gave recommendations of how we should report cancers. Then it was changed into being RESIST. RESIST went through an iteration of 1.0 and then 1.1. What I like about it is it comes up with it is just sort of out of the air, standardized assessment of complete response or remission by imaging criteria is where there is no perceptible cancer anymore, and all lymph nodes have decreased in size to a short axis dimension of less than a centimeter. Partial response is just everything is smaller. Everything is more than 30% smaller compared with the previous exam. Progression of disease is defined as a greater than 20% increase in the axis of all the patient's dimensions of disease since the patient's nadir scan. Stable disease is everything in between that doesn't fall into the other categories. So how does RESIST actually work? We measure no more than 5 lesions. There were trials that looked at, originally they measured 10 lesions, and they found that it didn't make any difference statistically whether you measured 5 or 10, you could still come to the same conclusion accurately. And we measure no more than 2 lesions per organ. So in this case, with malignant melanoma affecting the spleen predominantly, you've got 2 lesions. The white line represents the long axis dimension. You report the long axis dimension. The lymph nodes are periportal and peripancreatic. You measure the short axis of those lymph nodes. Like I said, 20% worsening is progression, 30% or more smaller is partial response. Anytime that there is a new lesion that is unequivocally cancer, it is progression of disease by RESIST. So how does it really work, and what are some of the drawbacks of this? How it really works is the patient presents and they have their initial staging CT. Their disease, their relative size of their disease is up here. They go on to definitive therapy. Sometimes that will be an example of somebody doing a right upper lobectomy and removing the 2-centimeter cancer, and at the follow-up scan, there's no cancer there. There were no lymph nodes at all because the PET was negative. That's a complete response. For this illustration, we've got a patient who's undergone chemotherapy, and their lesions have decreased in size by more than 30%, so they had a partial response. They then hit nadir, or their lowest point of disease. Their next scan, they had a little bit of growth, so we said stable disease, 4% increase. Their next scan, they got larger, and they met the criteria for progression. Some of the weaknesses of this are that not all of these scans happen at the same place. Sometimes the initial staging is going to be here, or maybe at a tertiary center. And then they come back here for some staging, and then they go somewhere else for other things. And so the other part of this is that looking back at the patient's list of prior scans, none of them have a highlighted thing that say, this is the nadir scan. It can be quite challenging to figure out where did the patient nadir exactly. And so the best thing that I've figured out to do is to read these one by one, but this is an area that is an ongoing opportunity for improvement by radiologists nation and worldwide, frankly. There are places that are trying to create a database that allow you to refer to prior scans, but that's not there yet. RESIST has been very, very popular. Anytime that we can produce a more standardized approach to medicine in today's world, it seems to be something that people embrace. And because of RESIST, since RESIST 1.1 came out, there have been all of these additional mechanisms of staging patients. I bring all of this up because I report with RESIST, but we also have a Lugano system that is used for diffuse large B-cell lymphoma that we use here as well. There's some slight differences between RESIST and Lugano, 5 lesions versus 6. Lugano requires a little bit more math to figure it out, but it's a way of staging patients as well, and so you may see reports referring to Lugano as well. So what are some other limitations in tumor response assessment? Definitely there can be inconsistent measurements between readers, and even sometimes myself, I look at my prior measurement and I go, geez, I was off by a little bit. So that can happen, but it usually doesn't lead to a statistically significant change. Ill-defined lesions can also be difficult to see. This is a GIST met to the liver. This is a potential weakness of RESIST if you're not paying attention. This is the long axis dimension of the patient's measurable disease currently. There is nodular enhancement in this lesion. Patient comes back 3 months or 6 months later and has had chemotherapy, probably Gleevec. In the meantime, the short axis dimension of the lesion is decreased and there's no more enhancement. At the next follow-up, lesion's smaller still. It's probably stable. It's probably a 15 or 20% decrease. But now there's nodular enhancement. So if you're reading the case just from numbers standpoint, it would be stable disease, but because there's new nodular enhancement in the lesion, it should be characterized as progression because that's new enhancement. This is another potential weakness and one of the reasons for other staging criteria. This is a hepatocellular carcinoma. This probably underwent, I don't remember, but it probably underwent chemoembolization. This was a case from the literature, not from here. And in the meantime, the lesion is smaller, so that's a positive, but HCCs enhance. They enhance avidly. They typically enhance early, and then they wash out and form a pseudocapsule later. And so this lesion has been, in my opinion, effectively treated, and it no longer shows internal enhancement at all. So RESIST would say either a partial response or stable disease, but in effect, this is probably completely treated. So here's our next unknown. We've got lesions, a lesion in the liver. We've got T1 in the upper right, T2 with fat suppression in the upper left, post-GAD arterial, portal venous and delayed phase, avid arterial enhancement on the delayed phase. I'll even give you the circle. On the delayed phase, this lesion has washed out, and so is a pseudocapsule. So we'll switch systems. So is this a hemangioma? Is this HCC? Is this a met from an unknown primary? Is this FNH or hepatic cyst? Okay, we'll take a look here. Okay, we're all over. This is a hepatocellular carcinoma. This is a classic HCC. Early arterial enhancement and washout on the delayed phase with pseudocapsule formation. This meets the UNOS organ transplant criteria for HCC, and it's what it was. So radiation dose reduction at CT is something that I've worked on since I became a radiologist, really. And at Mary Greeley and McFarland Clinic and Central Iowa Healthcare, all the places that we currently read for, we have worked on this with renal colic. Patients come in with renal colic, flank pain, radiating to the groin, typically is their history. Back in 2007, the American College of Radiology said that these exams should be, and they had good literature to support it, should be performed with a dose of 200 milligray centimeter, which equivalates to about 3 millisieverts of dose. So back in 2007, they said this. I was in residency at the time. I didn't know that they said it. I wasn't paying that close attention to the literature. In 2013, they said, oh, there's significant heterogeneity nationwide regarding adoption of our recommendation, which basically they said nobody was doing what they said, and it was true. Most places weren't tuned in to radiation dose reduction. Now, does it matter? Do we know whether radiation induces cancer at low doses? And the answer is probably not, but we don't know 100%. The next question is can radiation at a high dose induce cancer? And the answer is absolutely. This diagram is the best. It's an illustration of the best data that we have for this. This came from Hiroshima and Nagasaki. The survivors of the atomic bomb blast were followed to see whether there was induction of cancer. The white box represents the individuals who lived in Hiroshima and Nagasaki but were remote from the location at the time of the bombings. So they were typically the male soldiers who were not in Hiroshima and Nagasaki. Since they were able to map out where individuals lived in relation to where the bombs exploded, they were able to calculate the doses that each of these individuals received and then go back through the data later on. Low doses, up to about 100 millisieverts, is the number that should be stuck in your head. That doses below 100 millisieverts are pretty flat. We don't see an induction of cancer. Once radiation doses here on the x-axis, once it gets above about 100 millisieverts, the number of solid cancers in the population goes up and goes up considerably. Okay? So below 100 millisieverts, we don't know. Above 100 millisieverts of dose, we know that there is a risk of inducing cancer. Okay? Now, what about below 100 millisieverts? What really happens? We don't know. We just don't know. And there are arguments in the literature. So above 100 millisieverts, we do have an increased risk of cancer. Below 100 millisieverts, arguments exist between physicists, radiologists, whoever. There isn't, we don't know. Some argue that there is actually, this curve says that with low doses, some make the argument, that you actually reduce the incidence of cancer. that is a valid argument. I don't know if it's right or not. Some argue that the radiation risk or the cancer induction risk goes down to 0 and then is 0 for low doses. We have always historically assumed this linear no threshold model where we think that any dose may induce cancer, and I think that 50 years from now we may, I don't know where we're going to be with this. So, but where were we? So this is a fairly complex table. This was data that I obtained in September of 2015. The green bar at the bottom represents where ACR says our doses should be for the average for these exams. The beige bar, and each of these sites represents a particular CT scanner. The lower left, let's see if I can get my cursor to come back here. This is the Mary Greeley 16 detector row scanner. This is the Mary Greeley 64 detector row scanner. This is the McFarland Clinic's old Toshiba scanner. This is the Marshalltown McFarland Clinic old scanner. This is a Central Iowa Healthcare old GE 16 detector row scanner. And this is the newest Central Iowa Healthcare scanner. As you can see, all of them, the mean dose is this brown box. The beige box represents the lowest dose performed during the survey, and the dark brown box represents the highest dose administered to a patient during the survey. We were too high, and the red line represents our mean dose for all of our scanners during the time of survey, which was about 55 patients' exams that I surveyed. The yellow line and orange lines represent the national average dose in 2013 for these exams. So we were not only above the national average, but we were quite a bit above. After getting this data, I showed it to all the radiologists, and all of us kind of said, wow, we didn't realize our doses were that high. Wow. And we also didn't realize that there was quite as much variation between scans, that some patients had lower doses and some patients had really, really high doses. I take that back. Really, really high is an exaggeration. These were higher doses than they should be for the type of exam. And the highest doses were about 45 millisieverts. Again, 100 millisieverts is where we start talking about cancer induction, so these were higher doses than they needed to be. After talking to the radiologists and deciding how we were going to try to reduce dose, I then talked to all of the lead CT techs at all of the sites in person and told them about our project. A lot happened between, for me personally, between around September 2015 and when I resurveyed the data in September of 2016. I wanted to do this quarterly, but Caroline was born in December and it didn't happen then, and a lot of things have happened in my life since then. Nonetheless, in September 2016, I was able to resurvey the data. And the important thing is that I tried to use the same axes for the scale. Our doses came down a lot. Central Iowa Healthcare actually did, I would argue, the best job. The lead CT tech there basically just called GE and said, our docs want the dose below 400, make it happen. And they did, which was really good. In the meantime, we replaced the McFarland Clinic CT scanner, and its doses are also significantly lower. We had one outlier here, but everybody else was either at or below the mean. The Mary Greeley scanner, the old 16, is slotted to be replaced. It still has doses that are too high, and we do the best that we can with it. So, the blue line, we actually we didn't want to get to the green line. We intentionally wanted to go to twice what the ACR recommended. One, to make sure that we weren't missing anything, that we just wanted to make sure that we did all the scans appropriately and had buy-in. So that's why we didn't go to 200. We were trying to hit 400 and make sure that we didn't miss any stones, which is what we're really looking for on these cases. That being said, in November I had the opportunity to work, I have a part-time job at another institution, and was reading a CT and saw this, scrolling through the case, and was reading with a resident who was actually a first-year resident with two other fellows in the room, and started looking at the case, and it just looked grainy. Everything looked grainy. I've seen low-dose scans before, obviously, but this was a low-dose CT. And I start talking, wow, this is a really low dose. This is really a really low dose. Let's look at the dose sheet. And the poor first-year resident, she was just she's a first-year resident. She's trying to learn where the kidneys are and where the ureter is going to go and things like that. She's not even thinking about radiation dose. But the fellows in the room, who are about 6 months from taking real jobs, definitely got quiet and started paying attention. What is Dr. Lake talking about? And when I pulled up the dose sheet, I was really impressed. This was a 30-ish-year-old female who was mildly obese, not a very skinny person, but also not the largest person. But her dose at this place had a DLP of 80, which I was really impressed. And I was able to see her 2 and 3 millimeter obstructing stones at her distal ureter. So, okay, final unknown case here. We'll switch over systems. Is this, or are these, there's actually 3 lesions, and there's 2 different pathologies represented, so I'm trying to give you an advantage here. Of these 5 choices, 2 of them are correct. Hemangioma, HCC, METS, FNH, or hepatic cyst? It's not a hepatic cyst. Okay, let's see the results. Okay, METS from an unknown primary, good, because that's what one of the lesions is, and hemangioma is what the other. So we'll switch over systems and I'll go through it real quickly. So there's actually 3 lesions in total. The blue circles represent hemangiomas. These are T2 hyperintense in the upper right. These show progressive centripetal enhancement that nearly completely fills in on the delayed phase images. They look kind of funny, but that's what they are. The red circle is a vaguely T2 hyperintense lesion that does show between the T1 pre, this is the T1 pre, and this is the T1 post. This area enhances. And then the central part of the lesion enhances late. The take-home message, and this was one that this was a case, it was also a humbling case. I was a resident in residency getting ready to go do my MRI fellowship, and one of the MRI techs brought in this case. He knew that I wanted to do MRI and that I was going to do an MRI fellowship, and he said, "Doc, this is my mom's MRI. She has breast cancer. We have been all over the place in terms of we being the radiologists, the academic radiologists at that institution had been all over the place in terms of whether these were METs or hemangiomas or what were they, and we'd called them all different things at different times. Turns out when I had to go back, way back to her original scan, and she did have 2 classic hemangiomas that looked just like hemangiomas, and then she had this lesion, the red circled lesion, which was a MET, a definitive MET back then. She underwent extensive chemotherapy, multiple rounds of chemotherapy, and the take-home message that I took from it was that both METs and hemangiomas look quite a bit different than they usually do after the patient has received chemotherapy. And so hemangiomas can look a little bit different and look atypical after chemotherapy, particularly Avastin. So that's it. This is my wife in the upper left with Caroline, my oldest daughter, Grace, my middle daughter, Charlotte, and then Caroline's in the lower right. Are there any questions that I can answer?
Thanks for a great talk. What do you suggest when we see somebody who's a frequent flyer in the emergency department and they've already had 20 or more abdominal or chest CT scans? Do we warn them? What is there a protocol for what our ED docs do?
Yeah, good question. There isn't. Each time we do a scan, everybody gets an individual CT dose. So everybody who shows up for a scan, the scanner assesses them in the sense that they do a scout image, and then they look at their body habitus, and the machine calculates how much dose each person needs. we try to reduce our doses as much as we can, and we have, in the last 6 to 12 months, reduced our doses on a lot of our scans, especially our body scans, considerably. The head is unique. You've got a calvarium that you've got to penetrate, so you can't reduce dose that much in the head. But in the chest and abdomen, we can reduce dose and still see things well, and we have. So we can warn them they've had a certain number of doses, and our system calculates what their accumulated radiation dose, at least at Mary Greeley, is, but we don't have a wider database yet to be able to say this is what your overall lifetime dose. And the other problem is that we just don't have definitive numbers. The 100 millisieverts is a one-time exposure. It's not multiple low-dose exposures. We frankly don't know what we're dealing with multiple low doses. So to answer your question, we don't have a good system in place yet. Any other questions? Thank you.